I'm Geogy Vatakencherry, the program director of Kaiser, LA. And, this is kind of the aorta and the, happy New Year. You can see kind of the kind of where we're going. So this is kind of the spearheading of the West Coast Vascular Interventional Surgical Society, aka VIR. So for my background, I went to medical school solely to become a surgeon, similar to Kumar, who's going to be speaking later, who was a surgery resident and shifted to VIR. I was on surgical oncology service for hepatobiliary, and I enjoyed it. I did enjoy the anatomy, the surgeries, whatnot, but what I didn't like is how sick these patients got afterwards. They were miserable. Then the oldest patient in my service, an 80-plus-year-old gentleman with a Klatskin tumor, bile duct cancer, had a procedure done in this special place called IR, which I didn't really understand. And the next morning, he was smiling and eating breakfast like nothing happened with a Band-Aid on. And he went home that day. That was pretty shocking and unheard of for me. So that's when I realized that endovascular interventional surgery was the future of surgery now. And I wanted to be part of that. And so when I did my internship, I recognized how much I enjoyed patient care, and I would not compromise on that. So Dr. Daughter is the father of vascular interventional medicine. He was the first endovascular surgeon in the fact that he did the first endovascular procedure. He developed the concept of stents and thrombolysis. He's like the Elon Musk of medicine, so to speak. Cardiac cath and angiographic techniques of the future is a talk he gave at the Czechoslovakia Radiology Congress in June of 1963, June 10th. 6 months later, okay, he had prophesied in June that the catheter can be more than a tool for passive means for diagnostic observation. With imagination, it can be an important surgical instrument, i.e. surgery without a scalpel. He met this lady in January of 1964. And at that time, what he did was she had gangrene and bad heart failure. Rutherford 5, 3, 4, 5 gangrene. She was offered only an amputation because her heart was so bad, and she refused. And Daughter met her, used a wire, used these Teflon dilators, and crossed the occlusion. And she saved her leg. You can see auto amputated. And so the world of medicine changed from there forever. Now, the US, and people do not embrace change, and there's no different in the US. There was a patient that was referred for an angiogram, but they didn't want to fix. Daughter fixed her profunda instead and still save the leg. Well, we use that vascular highway. The blood vessels are a highway to do surgery from head to toe. So his colleague, Joseph Roche, who recruited from Czechoslovakia, had a cirrhotic with a GI bleed that he used autologous clot and stopped the bleeding. So what we do is open and close blood vessels. This heart attacks, stroke, reduction, blood clot in the lungs, PED, opening up blockage in the legs and saving the legs like Daughter did. Stopping bleeding also, whether it be intestinal, traumatic bleeding, intracranial aneurysms, you name it. We also kill tumors by using the blood vessels as a highway to stop the flow of blood to tumors and killing them. This is Cesar Gianturco. He developed the first kind of woolly coil. Okay, this is the Gianturco coil. This is Guglielmi, Fernando Winell, and Gary Duckweiler, who are all at UCLA neurointerventional team, and they developed and used a detachable coil to fix an intracranial vascular malformation aneurysm. Now, some of us consider it to be the fourth pillar in cancer care, and in the late 1970s, Dr. Yamada did the first embolism oncology and medical oncology. We have an existence in that space. This is the great Mason Sones, who's a pediatric cardiologist, who inadvertently did an initial coronary angiography. And this guy, Judkins, was Daughter's first fellow, went over to work with Mason Sones in Cleveland Clinic to learn coronary angiography, but he figured out an innovative way to do it all percutaneously without a cut down from the femoral instead of the brachial. So what he did was he accessed the femoral artery, developed what's used to this day, JR4, JL4, and a pigtail. And they became co-founders of the equivalent of SIR for interventional cardiology in 1978, president and president-elect. Pretty cool. Now, again, it was not embraced in the US, but in Germany, Eberhard Zeitler accepted this and embraced it and did a lot of PED interventions. This great guy, Andreas Grunzuk, who was later brought into Emory, listened to Daughter with great interest, as you can see. And he developed this balloon in his kitchen, and he did this, coronary angioplasty, in 1977. Julio Palmas figured out a way that before, if you did an angioplasty, you dissected or occluded, you had to go to emergency open heart. Well, he developed a scaffold to lay it open, and that was something that he brought. And millions and billions of people probably have this device in their body in the last 50 years. And he now has a vineyard. So if you have an opportunity to go to Napa Valley, you can check out the Palmas Vineyard. This great guy, Kurt Amplatz, was from Europe, developed cardiac surgical options for pediatric patients. So holes in the heart and the anterior septal defect or ventricular septal defects or PFOs, instead of opening the heart and doing open heart surgery, he was able to fix it through the femoral vein or jugular vein with these devices called the Amplatz occluders. He also developed a way to do urologic procedures without opening up the body called endourology, whether it be stone removal, etc. This guy, Perotti, was able to develop a device alongside with Julio Palmas to fix one of the first aneurysms in Argentina. Having said that, one of you guys who could be a third-year med student and something like that can be perhaps developed by you guys in the future. Slew of innovative people, from Daughter to Amplatz to Gianturco to Jean LaBerge to Katzen, Dake, Beninati. All did so many things. This is the TIPS procedure for liver bypass made by Colapinto. So many different things that are available. Again, a lot of different devices that Dr. Matasseri is an expert on, from lasers, the CAT lasers, Dr. Matasseri's kind of expertise, but there's also different atherectomy devices and different stent grafts that are available and different ways to get into the vessel, tiny little catheters to block tumors. This is cryoablative technology. Now we're able to treat more and more diseases, whether it be obesity, arthritis, orthopedic surgeries, removing clot, etc. Now, this is an important quote. I encourage you to read this and take it to memory. Excuse me. So basically, what he said was, if you're just a plumber and you don't do clinical care, you're not going to do this for long. And so that's an important quote that you need to really understand. He said that 4 years after his initial intervention. So really, the most important evolution of our field has been longitudinal clinics that are lifelong and comprehensive care for patients. This is the original OG of clinical VIR, Barry Katzen. He founded the Miami Cardiovascular Institute. Many of you have gone to the ISET meeting, which is live cases. And many of you understand he established in Virginia and later in Miami. Well, you wrote a publication, JACR, explaining the importance of clinic and VIR. It still has not been adapted to the extent that it should be. Thomas O. McNamara was my mentor, who I went to California to work with, really, because he was a clinician. He did his own wound care. He admitted his own patients and saw 30 patients in the office in a week. And really, our practice is based on his tenets. I was lucky enough to be sitting at the meeting where McNamara got awarded at the ISET meeting a few years ago, between these two great legends of clinical VIR. So there was a great lecture by Katzen at 2008 Jest where he talked about the death of interventional oncology. Why was that important? Well, this is an Eamon Hobbs, who's the president of Angiodynamics. He developed a slide about the danger of the life cycle of VIR, and you have to break it. We're generate innovations, generate an idea, develop it, then it starts to migrate out of our specialty with the residual. Why is that? Because we relied on specialists to tell us what to do instead of deciding what to do. And we have to be able to talk to patients directly about their disease, follow them forever, and comprehensively manage them. We have to get referrals from primary care, ER, urgent care, and hospice. Specialist referrals are not sustainable. So the past, it would be patient to PCP, to specialist, or surgery to VIR. Now patients come directly to us, or to PCP and then to us. So we got to recruit the right people. It's not imagers, not radiologists, but people who care about patient care, who have the stamina to handle the hours and the emergent nature of our field, who like working with their hands. And we got to stop training on esoteric diseases that really are not relevant to us. We need more time in the unit, more time spending on common conditions like arthritis, diabetes, and hypertension. So this is the great Andreas Adams, who's the president of BSR in the past and gave the 22nd daughter lecture. And he said, Vini Vidi vanished. Again, he said, we can't fish from the radiology pond. And that's why we're developing the meeting to recruit from a surgical, interested trainees. Really, this is surgery. And I think that's the key thing you have to understand. We got to focus not on these skeletal dysplasias and rare disorders. We have to understand the tools and trade for the 5 or 6 years of our training, not 1 or 2 years. It's inadequate training. We have to keep the patients public safe. So really, we got to recruit surgeons, and we got to train them like surgeons, not like imagers and lost for 3 years in this kind of netherland. And really, when we built the RFS in 2010, our goal was to focus on the patient as opposed to procedures. Now, how do we do this? We developed the concept of the VIRIG, which is the Vascular Interventional Radiologist Group, or VIIG. And the VIG is basically focused on medical students who want a primary role in patient care, who are passionate about surgery and are not afraid of the lifestyle of a surgeon. And radiology does teach you anatomy, pathology, head to toe in an efficient fashion. But really, for me to have good outcomes for my patients, I have to understand physiology, echo, PFTs, ABGs, right heart pressures, pharmacology, management of diabetes, hypertension, hyperlipidemia, antiplatelets and anticoagulants, and microbiology. Now, it is not easy to learn head to toe anatomy and pathology, and that's where radiology comes into play, but it is not the be all end all. You don't learn how to do a physical exam, history taking, admitting patients or managing ill patients, and counseling patients, which is really the crux of what I do on a weekly basis. Now, we became a specialty in September 11th of 2012, the 37th primary specialty, which is a big deal. And the rationale was we have to understand that we had to change our pattern of training. We still haven't done it to the extent that we need to, but we're working on it. And so that means having an outpatient clinic with lifelong longitudinal care of patients, inpatient consulting service, and mid-year own patients. I mean, I've been lucky enough to take care of patients who had locked-in syndrome, who couldn't walk or talk, and allow my neuro colleagues to do a basilar thrombectomy, which is 90% mortality. This young guy was able to come off the table, walking and talking. Fibroid therapy for abnormal uterine bleeding, complex aortic repairs with physician-modified grafts. It was one of my first Berger patients who I did one of my first pedal loops with Dr. Consagra, who'll be talking later, and a pedal loop, and she went from an AKA or BKA to a TMA and is able to walk and is a big proponent of stopping smoking. One of my early angiovac cases where a guy who couldn't walk, we were able to do a thrombectomy on. This is a Takayasu's patient who had diminished cerebral hyperperfusion. Along with my neuro colleagues, we did a carotid subclavian angioplasty of the bypass. So what do we need to do in the couple of minutes left? You got to focus on the basic sciences, pharma, micro, anatomy, pathology, physiology, first 2 years. Crush your step 1 and step 2 and own heart, lung, liver, kidney, brain. Cardio, pulmonary, nephro, neurology, and hepatology are critical to being good VIR. Surgery is key. You've got to crush it. You got to be the first and last at and own it. That's going to be highly important. And EVIS is modern day surgery. Internal medicine, because of how sick our patients are very important. Now, 4th year matters. Take it seriously. Make it count. Do 3 VIR busy sub-Is. Spend time in clinic and consults, not just in the back tabling. Vascular surgery and surgical oncology are high yield rotations the 4th year, and we look at those letters seriously. And intensive care unit and cardiology are also to kind of close it up. Do a surgical internship, not a TY. If you do a TY, then we don't think you're serious about the specialty or about patients. VIR lack of clinic is huge, so you need to get clinic. Currently, they only do 3 VIR blocks. You need more. Our model is 8 months of VIR the first 3 years, including call, a lot of ICU and CCU, and tons of dedicated VIR lectures in clinic. Clinic is key. Our residents go to weekly clinic. And if you look at Karthik, who taught me about this, if you look at our clinic is 125 days now compared to 115 IC or 215 BS, compared to 10 days in traditional IR training. Has to change. This is Bot, who's going to be giving a talk with Harut, one of my graduates, doing a complex CLI revascularization, pedal access, retrograde, antegrade, and then this is the end, Harut, kind of debriding the wound. So we're not just plumbers. We have to do good wound care. We have to offload. We have to do infection control. We have to make sure an appropriate diabetic control, and you have to comprehensively manage them and follow them for life. So I want to be known as a patient's doctor, not known as a doctor's doctor, and I think it's an important distinction from our DR colleagues. Benenati and Katzen, and Benenati is this basic, and it's true. If you want to have true enjoyment of your career for the next 30, 40 years, follow your patients, develop a rapport with them. So again, MS4 is the beginning of your 7-year training period, surgical internship, ICU integration, and a clinic. This is the future of surgery. It is unethical to practice like we did in the past, and clinic is a cornerstone. Remember this as a parting statement. Patients fight hard, so we need to train and fight harder. Thank you.